Thank you.
Well, good evening, everybody. My name is Dr. Suleiman Faturi. I'm speaking to you all from New York City, where I practice medicine. I'm an assistant professor of medicine and an attending physician in hematology and oncology. Today, I'm going to be speaking to you guys about pulmonary embolism and DVT. This is a pretty vast topic, and so what I've tried to do, given our time, is to make this more concise and go over some of the key parts of what I think as medical students you guys should be familiar with, certainly some of the clinical aspects of what we call venous thromboembolism. Towards the end, we'll go over some questions, and if I find that we're running low on time, I'll try and speed up some of the presentation and share my slides with you guys following this. Sorry, I'm just gonna. So to begin the lecture, when we first talk about pulmonary embolism and VTE, these are both a spectrum of a similar disease. They're both interrelated. And essentially what venous thromboembolism describes is the diagnosis of a DVT or pulmonary embolism. Whereas a DVT is primarily a formation of thrombi in the deep veins. And as you can see in the diagram here, I'm sorry, let me go back there. What the deep veins of the lower extremity are, beginning from the inferior vena cava, extending down to the common iliac, the external iliac, and the internal iliac, and going down into the deep femoral and the perineal. These are part of the deep veins, what we call proximal parts of the lower extremity vasculature system. Below the knee is what we call more distal DVTs, and the kind of clinical consequences of these distal DVTs are a little bit less worrisome, and we'll get into that a little bit later into the lecture. The spectrum of diseases ranges, from patients who sometimes have no clinical symptoms of DVT, sometimes even no clinical symptoms of pulmonary embolism, to quite significant symptoms that can sometimes appear. In fact, massive pulmonary embolism can sometimes cause death. It is very important to be familiar with this subject. It is quite high yield, certainly on your exams, but in clinical medicine, you will certainly come across this multiple times a year in your patients. In fact, thromboembolic disease is the third most common acute cardiovascular disease after patients with cardiac ischemic syndrome, such as myocardial infarction and stroke. And untreated, a proximal DVT can cause clinical PE in about 33 to 50% of patients. And we do know that untreated PE in some cases can cause death. The epidemiology has a significant impact, this disease, both in terms of morbidity and mortality. This is both in the United States and in Europe. And so I have a little bit of information here on the cases based out of the European Union, in which in a particular year, they see about 465,000 cases of DVT and more than or approximately 300,000 cases of pulmonary embolism. And of these, about 370,000 related deaths to VTE were seen. In the United States, pulmonary embolism by itself accounts for about 100,000 annual deaths. And here in the United States, we see approximately close to 1 million cases of DVT and PE yearly. About 33% of patients who have a DVT can have long-term complications, what we call post-thrombotic syndrome. And about a third of people with DVT and PE will have some type of recurrence in about 10 years. The prognosis overall certainly depends on the extent of the DVT or PE, depends on the size and the anatomic location. However, we do know that about 250,000 hospitalizations in the United States happen annually because of this disease. And it does account for about 5 to 10% of all deaths. About 1/3 of PE cases are fatal. And of these, about 67 percent are kind of diagnosed after death. Sudden death is the first symptom in about 25% of patients who have a large pulmonary embolism. And there is a high rate of clinically unsuspected DVT and PE that can lead to significant diagnostic and therapeutic delays. We'll later go over some of the differential diagnosis of patients presenting with symptoms such as chest pain and dyspnea. And the important part of this is making a very quick diagnosis in order to begin treatment rapidly, given patients can deteriorate quite quickly. Studies demonstrate that there's about a 95% risk reduction when you treat thromboembolic disease rapidly. However, a risk of recurrence following the discontinuation of treatment has been seen, and there are certain risk factors which may increase the risk of recurrence. And about 5 to 7% of all recurrences in these cases can be fatal. To talk a little bit about the pathophysiology of thrombosis is really to kind of talk about coagulation itself. You all may be familiar with this from your basic sciences, but a thrombus, as you all know, is essentially composed of platelets and fibrin. There's in addition in the thrombus, you'll see things like white blood cells, and these things kind of form within a blood vessel. There are a lot of different components of both prothrombotic and antithrombotic components in the body that is happening during acute thrombosis. And as you all know, that homeostasis in the body, or an appropriate balance of these inhibitors and also antithrombotic elements, is important. Thrombosis can occur if there's, for example, a decrease in certain antithrombotic factors, natural factors such as protein CNS, or there's an increase in certain coagulation factors where thrombotic events may occur. Some of these thromboses can occur as a result of damage to the vessel wall or abnormalities. And we all know that blood hemostasis is primarily controlled by enzymes and coagulation proteins. We have primary hemostasis that is primarily driven by platelets and the platelet plug. And then the secondary concepts of hemostasis, which includes things such as the intrinsic and intrinsic pathways that ultimately leads to a blood clot itself. You guys all may be familiar with the coagulation cascade. This is a busy slide, but an important slide. And the reason this slide I bring up, I'm sorry, I'm just trying to, Dr. Limi, is there any way possible to remove, sorry, this prompt has come up, which doesn't allow me to see the full screen. Someone is trying to record, which is okay. I just want to see if I can remove that prompt by any chance.
Sorry, I couldn't understand what you said.
There we go. Actually, I was able to fix it. I apologize.
All right.
Okay, great. So when we look at the coagulation cascade, as you all know, that this cascade happens in terms of two processes. Both will lead to what's called the common pathway, which is ultimately the activation of factor 10. The extrinsic pathway, which is to the right, which we do measure by blood tests, for example, the PT blood test helps you to measure the extrinsic pathway. This is usually stimulated when the body sees things such as trauma, for example, a gunshot wound, a stabbing victim, patients who have hypoxia, sepsis, malignancy or inflammation, in which tissue factor will be exposed to plasma procoagulants, and through the processes, factor 7 will subsequently activate factor 10. Activated factor 10 then produces this complex that will generate prothrombin, which is factor 2, through thrombin. And thrombin helps to generate fibrinogen to fibrin, which ultimately leads to the fibrin clot through the activation of factor 13. With the intrinsic pathway, this is primarily activated by exposure to endothelial collagen or surface damage after endothelial damage. So for example, think about inside the blood vessels, some type of issue going on. And as you can see there, the different factors that are involved These are areas in which treatment with anticoagulants can help in terms of causing anticoagulation by inhibiting things like factors 2, 7, 9, and 10, which is done by the medication Coumadin. The new direct oral anticoagulants can affect thrombin itself. We do know that certain diseases, like patients who have hemophilia or von Willebrand diseases which can cause bleeding, will be affected by things such as factor 8. And patients will then present with elevated levels of PTT. The PTT helps us to measure the intrinsic pathway. Causes of venous thromboembolism primarily have been described by Virchow's triad. As you all know, Dr. Virchow was a prominent physician who we call the father of modern pathology, who practiced in the late 19th century. And he proposed essentially 3 systems that help increase the risk of thrombosis. These 3 systems also work together. For example, the first is stasis, where there's alterations in blood flow. These are patients, for example, who have long periods of immobilization that we'll get into later on. Vascular endothelial injury, for example, a patient exposed to chemotherapy, patients who are exposed to certain sepsis, which can increase the risk of blood clots, or alterations in the constituents of the blood. These are patients who may have inherited or hypercoagulable states. For example, patients who present with antiphospholipid antibodies or have certain genetic causes of thrombophilia like factor V Leiden mutations. Dr. Virchow had described that about 90% of all clinically important pulmonary embolisms results from DVTs that occur in the deep veins of the lower extremity, primarily the proximal. However, we do know that emboli can also originate from the pelvic veins, the inferior vena cava, and the upper extremities. Upper extremity blood clots primarily are secondary to catheters that are placed in the upper extremity. For example, ports that are placed, dialysis catheters that are placed. And most pulmonary embolisms, including DVTs, have similar risk factors. When venous stasis does occur, venous stasis, again, being a product of immobility, this causes several abnormalities of coagulation factors or natural anticoagulants to increase blood hypercoagulability. The vascular wall injury promotes circulation of coagulation enzymes and cofactors. And when there is this stasis that happens, these essentially naturally decrease. Again, we know that risk factors for thrombosis may be provoked or unprovoked, which we will get into, transient or persistent. And they can be described as risk factors that are strong, moderate, or weak. The causes of venous thrombosis can really be divided into 2 groups, those that are hereditary and acquired. And some patients will have multiple different risk factors that can arise. Pulmonary embolisms essentially occur when clots break off and embolize into the pulmonary circulation. And most patients will present with multiple pulmonary emboli. Usually the lower lobes are affected. However, sometimes you can see the upper lobes affected and what we call central pulmonary embolus, which has a significant morbidity. These large emboli that kind of obstruct the main pulmonary artery can cause what we call a saddle embolus. And these conditions increase the risk of dangerous cardiovascular consequences. In fact, these saddle emboluses are primarily the cause of sudden deaths in most patients that present with pulmonary embolism. When patients have pulmonary embolism, this essentially leads to impaired gas exchange. Given the obstruction of the pulmonary vascular bed, this leads to a mismatch in the ventilation perfusion. Although the ventilation remains the same, the decrease in the pulmonary blood flow leads to dead spaces in the lung. When these dead spaces occur, there's other mediators such as serotonin. As this is released, it causes vasospasm. This further decreases pulmonary flow. And so when we talk about disease in general, in terms of pathophysiology, it's not just one system. Multiple systems kind of are working together. The extrinsic pathway and the intrinsic pathway work together. Multiple risk factors work together in causing these. Here, the diagram that you guys see to the right will show us a little bit about a kind of a rough schematic of the vasculature and blood return that we see in the pathophysiology of pulmonary embolism. So, for example, when a patient has a pulmonary embolism, as you can see in the diagram to the right, as it comes up from the pelvis or the legs, the blue will be the venous return, and the red obviously is the oxygenated blood. But as the embolus goes through the pelvis and legs up through the inferior vena cava, we're now looking at the blue part of the diagram. It goes through the right atrium and in through the right ventricle, up from the right ventricle, goes into the main pulmonary system. If a patient has a large pulmonary embolism that will sit usually here at the main pulmonary arteries, that's right in the middle, this will decrease a backflow of pressure into the right ventricle. When the right ventricle resistance increases, this increases the afterload, this decreases right ventricular outflow. In turn, it can cause dilation of the right ventricle, which can be a finding when you are seeing patients on physical examination. Patients can then have what we call a flattening or bowing of the septum because of this right ventricular dilation. This is a finding that we see on echocardiogram. As this happens, the decrease in the right ventricular outflow and the concomitant dilation will ultimately decrease left ventricular filling. And when left ventricular filling decreases, this ultimately decreases cardiac output and will cause then systemic hypotension and hemodynamic instability. The pathophysiology of DVT essentially, again, are blood clots that happen in a similar manner but begin in the lower calf veins. Again, about 10 to 20% of thrombosis extend proximally. So they'll begin in the lower distal and then move upwards. And about 1 to 5% will go on to develop some type of fatal pulmonary embolism. Virchow's triad also applies to the pathophysiology of DVT. As you guys recall, both DVT and PE have similar pathophysiology. And venous stasis is really one of the most consequential of the factors, but it's not really the only factor that seems to be at play. We know that most venous thrombosis is multifactorial, and this is important to note. As in the endothelium, when we see thrombosis, this can stimulate cytokine production and inflammation, which in turn increases more the risk of venous thrombosis. The stasis that results increases viscosity and formation of further microthrombi. And this, again, doesn't allow washing away by fluid movement. And so it helps to propagate the thrombosis. And thrombosis in the lower extremity typically occurs in the pockets adjacent to the valves. And so the area of the valves, although help to regulate backflow, are areas where we tend to see higher rates of thrombosis. And so there are potential locations for stasis and hypoxia. This is why we tend to see them in these areas. So to talk a little bit about types of pulmonary embolism, again, there are different types. The main things to kind of note from this slide are those patients who present with very large pulmonary embolisms, which cause hemodynamic instability. Previously, this was called massive or high-risk PE. And these are patients who will present with these central pulmonary artery thromboses, which again can lead to hypotension. We define that typically as systolic blood pressure is less than 90, or a drop of more than 40 from their baseline. A lot of these patients will need treatment with vasopressors or inotropes. Some of these patients will ultimately die from obstructive shock from severe right ventricular failure. And patients who have hemodynamically stable PE is a spectrum ranging from small to mildly symptomatic or asymptomatic disease. This is ultimately the more common ones that you may see, certainly in the outpatient setting. Most of these large pulmonary embolisms will happen in patients or patients who are presenting to the emergency room in critical condition. Again, some of these small or low-risk pulmonary embolisms may cause mild hypotension, but they usually stabilize in response to fluid therapy. Let's talk a little bit about some of the risk factors that we can see for thromboembolic disease. And there are a lot of different risk factors, but essentially we like to kind of divide these in different categories, including patient-related factors, certain disease states, surgical factors, hematologic disorders. And risk is additive. The more risk you have, the higher risk you have of DVT or PE. And the higher risk you have may also help us kind of determine the duration of your treatment following initial treatment of a PE or DVT. Certain patient-related factors, for example, older patients tend to have a higher risk. Obese patients, obesity itself is an independent risk factor for thrombosis, typically in patients who have a body mass index over 30. Patients who have varicose veins, the use of estrogen, especially in oral contraceptive therapy, smokers, pregnancy by itself causes a hypercoagulable state. It is a very high risk factor for pulmonary embolism and DVT, immobility, and also recent surgery. And so when you are seeing a patient and obtaining a history, these are the important questions to ask the patient. Have you had recent surgery? Is there any underlying history of cancer? Are you an active smoker? Because these can help us determine their risk factors. Certain diseases inherently increase the risk of thrombosis, and malignancy is one of the highest. In fact, thromboembolic disease is probably one of the highest reasons that patients will ultimately die from certain cancer-related deaths. Other conditions are congestive heart failure. Again, this may deal with things from vascular injury to hemostasis of the blood, nephrotic syndromes, where some patients will lose things such as natural anticoagulants like antithrombin 3, recent myocardial infarctions, those patients with inflammatory bowel disease such as Crohn's disease, spinal cord patients who are paralyzed and are usually confined to a wheelchair, and certainly patients who are undergoing orthopedic surgery of the pelvic, the hip, or some of the long bones where they come in with fractures, femoral fractures, hip fractures. Surgical factors are certainly a risk factor. In fact, mostly in outpatient, when we are dealing with patients with DVT or PE, or inpatient consultations will be in these patients who've had recent surgery, who either we are consulted on for prophylactic treatment or active treatment of a thrombosis. And depending on the type of surgery, the risk can be higher. For example, a patient who is undergoing a surgery to remove a mass that has been deemed to be cancerous in the abdomen may have a higher risk. Thoracic surgery may be a high risk. Hand surgery, on the other hand, patients are going in for a carpal tunnel release, may not see as much of a higher incidence. So certain types of surgeries will have higher risks of blood clots and DVTs. In certain studies, following certain pelvic surgeries, about 40 to 80% of patients had calf DVT in these studies. 10 to 20% had thigh vein thrombosis. And fatal PE had developed in about 1 to 5% of these patients. And so it's very important when you are seeing patients, when you're consulted on for anticoagulation prophylactically in high-risk patients, that the type of surgery is utmost important to know. Again, this is just a slide that you guys can take a look over later. We'll talk a little bit more about the inherited thrombophilias, but below you'll see the multiple different risk factors for the development of venous thrombosis. On the bottom, you'll see things such as myeloproliferative neoplasms. This is hopefully a lecture that I'll be able to help with you guys later on. But the two conditions that fall under that category are polycythemia vera and essential thrombocythemia. Inherited causes of venous thromboembolism are not common. We do see this in practice, but it is not a very common thing that we find. These inherited disorders, as you may know, are typically patients who have the factor V Leiden mutation, the prothrombin gene mutation, protein C or protein S deficiencies, which are natural anticoagulants, and antithrombin 3 deficiency. And the most frequent cause, the majority of these cases, about 50 to 60%, are primarily the factor V Leiden and the prothrombin gene mutations. Defects in, again, protein S, C, antithrombin account for the remaining cases. In my practice, for example, factor V Leiden and prothrombin are the most common. I do see patients for protein C or S. Antithrombin 3 is a pretty rare cause of these blood clots. So let's look a little bit about, this chart kind of looks at genetic and acquired risk factors for a first episode of venous thromboembolism. For example, the risk for a patient who has prothrombin gene mutation maybe
مسئولین عزیز مایک تان خاموش کنین بی‌نظمی نکنین. Sir, you can mute their mics.
Okay, sure.
You have the authority. Yeah.
Okay. So the prothrombin gene mutation, as you can see, the relative risk for a first episode versus the general population is about 2.8%. For example, someone that is on an oral contraceptive, that risk is even higher. Patients who have factor V Leiden mutation, that risk is about 7. But someone that has a factor V Leiden mutation, a heterozygote, homozygous is not common, although that risk is much higher. But if that patient is taking, in addition to that, an oral contraceptive, you can see how much higher that risk is. And we'll talk a little bit about testing certain patients who may have a strong family history, although they may not have a blood clot. If they are interested in going on an oral contraceptive, it's important if they present to you in a concern, hey, I have a very high family history of blood clots, we do check these patients because we do not want them on oral contraceptives if we can identify a factor V Leiden mutation. When we look at the prevalence of inherited thrombophilia and associated VTE risk, as you can see again that the antithrombin 3 deficiency, the prevalence in general in the population is not very high. So as we go down the list, most commonly, again, are the factor V Leiden mutations and the prothrombin gene mutations. Now, if you do have an antithrombin 3 deficiency, your risk of a blood clot is much higher, about 16-fold increase than a patient that may have factor V Leiden or prothrombin gene mutation. The most common cause, however, of thromboembolic disease will be acquired, meaning a patient may present with multiple different risk factors. And this was a study that looked at some of the incidents of venous thromboembolism from residents in Massachusetts in 1999. And what they found, as you can see below, that the most common, the 6 most prevalent, certainly patients that had more than 48 hours of immobility in the preceding month. And immobility can be defined by certainly multiple different factors. A patient that is, I had a patient that I saw recently that took a flight from South Africa to New York. This is a long period of immobility. In addition to that, as we mentioned, there are multiple risk factors. This patient also was on oral contraceptive that was recently started. So the two were combined to create the perfect system for a blood clot. The other high risk factors was a recent hospital admission. When you're in the hospital, you're acutely ill. The inflammatory system has been revved up in the body. You're not moving as much. And so perhaps you've had a surgery or a procedure in the hospital. Malignancy absolutely is one of the highest. In fact, patients who are presenting with metastatic disease, especially patients with certain gastrointestinal malignancies, some of these patients we put prophylactically on anticoagulation because we know how high the risk of blood clot may be. Infections, certainly infections which need long-term antibiotics, especially infections that need long-term antibiotics with catheter placements. And obviously current hospitalization. So when a patient presents for an evaluation, we ask them these questions. They're very important when we get to the history and physical. So category risks regarding venous thromboembolism in surgical patients. Remember that we briefly touched upon this. I won't go through this entire chart, but it will be there for you to review. However, every surgery, as you may know, is low risk, moderate risk, or high risk. This also applies to patients when we look at cardiovascular risk, low risk surgeries or high risk surgeries, who needs cardiac clearance, etc. But we do know the older that you get, the higher risk of surgery, that the risk of thromboembolism will increase. Some of the highest risk patients are really patients who have orthopedic surgeries, patients who have spinal cord injury and are undergoing surgery, major trauma. And again, these patients present with a multitude of different problems that increase blood clot, not just because they have the fracture, but on top of that, they're bleeding. They have vasculature that has been altered in the trauma. They have an underlying spinal cord injury, which releases significant cytokines into the body. So it's important to know that it's not just one process, that multiple processes lead to these conditions. When you're seeing a patient, the important parts of your history and physical in both pulmonary embolism and DVT can help you determine what condition the patient is in and how quickly you need to start treatment. Remember, if the patient is presenting to you with a large pulmonary embolism, you don't have the liberty of waiting several hours to make a decision. It's very important for you to immediately be able to determine the condition of the patient, and in some cases, even beginning anticoagulation before confirmatory test results, such as a CAT scan angiography. We do know that the morbidity can be quite high, and that about 30% of untreated patients with pulmonary embolism will die, but only 8% if you make a timely diagnosis. So what are the most common symptoms that patients present? And again, there can be a range of symptoms, but the most common that we see are patients who present with shortness of breath. Usually it can be acute, sometimes severe. Patients can have pleuritic chest pain. This means that as they take a deep breath, they're feeling pain. They can have cough, hemoptysis, cough when bleeding, although this is not common, pre-syncope or syncope. And this is certainly seen in patients who may have a decrease in their cardiac output, leading to a syncopal episode. Patients who have a central pulmonary embolism are patients who may then come in with some type of right ventricular ischemia. These patients can then sometimes go into certain arrhythmias, such as atrial fibrillation. And although hemodynamic instability is rare, it's an essential form of clinical presentation, as it really indicates central extensive PE with severe hemodynamic reserve. So if that patient who presents chest pain, shortness of breath, and they are coming in with hemodynamic instability, it is critical that you make a very quick diagnosis. Remember that when you're seeing these patients, again, questions to ask. Again, are you using oral contraceptive? Has there been any recent surgery? Is there any prior history of venous thromboembolism or a family history of venous thromboembolism? Patients who present with DVT have certain physical examination findings, such as calf pain or tenderness, usually in one extremity. Sometimes it can happen in both, but usually it's unilateral. They can have swelling with pitting edema, swelling below the knee. Usually this is seen in distal deep vein thrombosis. And it can be seen even up to the areas of the groin when there is a proximal deep vein thrombosis. The skin temperature can be increased. Sometimes the patients will have erythema. And in very severe cases of obstruction, you can see cyanosis of the lower extremity. Apart from symptoms of pulmonary embolism, again, it's critical to look for risk factors. This can help with your differential diagnosis. You may see, again, tachypnea, tachycardia, which are common, but again, non-specific findings. So if a patient presents to you with not all of the findings, that doesn't mean you can rule out a pulmonary embolism. When you see patients with any type of disease, what you learn in the textbook is very different what you can see clinically in patients. In addition to some of the findings in the lower extremity, on physical examination, you may hear decreased breath sounds. Sometimes you may see elevated neck veins from signs of pulmonary hypertension, a loud P2 component of the second heart sound, a right-sided gallop. And in some patients, you may even see a parasternal lift. The chest, you'll see when the heart beats, movement of the area of the chest. And this is typically seen when the right ventricular has now caused dilation. We know that pulmonary embolism is a well-recognized cause of sudden cardiac arrest. So you may hear that a patient had sudden death at home and sudden death in the hospital. And a lot of these are from a massive pulmonary embolism. Patients who have pulmonary embolism and then suddenly develop things like bradycardia, remember that this can sometimes be from a right bundle branch block. And so again, identifying these patients is very important. And anyone who has hypotension with jugular venous distension, whereas you've ruled out things like myocardial infarction, tamponade, or tension pneumothorax, then a PE should highly be suspected. Here are the differential diagnosis. As you can see, there can be multiple different things that can present similar to a DVT or similar to a PE. So this is where kind of both experience and in addition to that, a good history can help you differentiate. You know, a very bad cellulitis sometimes looks like a DVT, although the patient may say, well, you know, I've had fever, and on top of that, I developed a area of abrasion that later, started to become red, and well, maybe it's more cellulitis. Patients who may have a ruptured Baker cyst can sometimes present with an acute pain behind the knee. Patients where differential diagnosis for pulmonary embolism can be things such as congestive heart failure, or patients presenting with ARDS, certainly myocardial infarction, pulmonary hypertension. So that patient who presents to you with chest pain, shortness of breath, certainly as part of your workup, you will be getting your EKG, you will be performing your X-ray, because you are looking now at a differential diagnosis and trying to rule things in or out. The diagnostic approach for patients with VTE, you may all have heard of what we call the Wells criteria. This is a pretest probability score that we use. And this kind of helps us determine if we should move on to the next confirmatory test. Should every patient that comes into the emergency room undergo a CAT scan for presumed pulmonary embolism? And the answer is no. It's very costly. And these pretest probabilities can certainly help us. And what the Wells criteria is it gives you a score system that you can see. Based on the score systems, you're given then a high score or a moderate and low score. And when you have these high or moderate or low scores, that will then tell you the possibility of a pulmonary embolism, which will then allow you to go on to the next step of diagnosis. For example, if a patient presents you and says, I have leg swelling and pain, in addition to that, I've recently had surgery, then they've already reached a score of 4.5. And on top of that, you find that they're tachycardic. They're now at a score of 6, which puts them in a moderate to high category. A score of less than 2 and a negative Ddimer, that usually can help you rule out a PE or even a DVT. What about the role of a Ddimer? As you recall from the first couple of slides that we showed, Ddimer is a degradation of cross-link fibrin from fibrinogen, and it's elevated in nearly all patients who have an acute thrombosis. So when you find a patient that has a low pretest probability with a negative Ddimer, the likelihood of a thrombosis is pretty low. But Ddimer is very nonspecific, so it's not a test that I recommend that you use unless you have a low pretest probability. For example, it can be high, as you can see on the right side of this slide, from multiple different causes: sepsis, COVID, infection, stroke, acute myocardial infarctions, liver disease. The list is quite long. pregnancy, even in normal pregnant patients. So in some patients, however, especially those patients who are presenting to you in an outpatient setting who have mild symptoms of a DVT, sometimes in these patients, the D-dimer may not be very helpful and can be negative. And so that's where you have to really use your clinical suspicion of ordering the next appropriate test. Here we can see again from this particular slide, when you are evaluating patients with low probability of PE, again, if you really rule out a PE based on the criteria? If the answer is yes, then your next step is you don't order any further testing. The pulmonary embolism has been excluded. The patient does not have a heart rate less over 100. They are oxygenating well. They are not acutely ill. They're young patients. They don't have lower extremity swelling. They're not on any medication that may increase the risk. And their Wells criteria is less than 2. If you say, well, they have some of the risk factors, not all, but they had a low probability to begin with, well, that's when you measure the D-dimer. And if your D-dimer is less than 500, then your next step is that the patient unlikely has any type of pulmonary embolism. But if that D-dimer is high, or a pulmonary embolism cannot be ruled out based on the criteria that you see in that box there, then you should go to the next step, which is essentially a CT pulmonary angiography. And if that is positive, then a PE is diagnosed. If it is inconclusive, then we go to other scans such as a VQ scan, which is a ventilation perfusion scan. In patients who don't have a high probability, these patients should go under appropriate testing. You do not use your Wells criteria. You've already told me that the Wells criteria is over 6. You do not use your D-dimer. These patients should go straight to definitive imaging, usually CT pulmonary angiography. If it is not available, a ventilation perfusion scan. Some patients ask, does a CAT scan with contrast, is that sufficient to rule out PE? And the answer typically is no. It can certainly help identify pulmonary embolism patients, but we don't find that to be as highly sensitive as CT angiography. In some patients, or if you're in a place where you don't have capability of the CAT scan, then try with an ultrasound to look at the lower extremity, because we know that the majority of pulmonary embolism arises from a lower extremity DVT. So if you see the lower extremity DVT on the ultrasound, then the treatment for pulmonary embolism and DVT is typically similar. Begin to presume they may have that pulmonary embolism if they are having symptoms in the chest. So the diagnostic testing for DVT, simple, not expensive, is really ultrasound with Doppler is what I usually order and what I recommend. Doppler helps with the evaluation of flow. Other less common tests are things like CT imaging with contrast, magnetic resonance venography, or venography itself, rarely used. Some instances that I've used this are to evaluate the pelvic vasculature, in which sometimes if we are highly suspicious of a pelvic etiology of thrombosis, especially in patients presenting with PE, that certain underlying tumors in the pelvis can sometimes increase this risk. For example, GYN malignancies. What about hypercoagulability? So this is a busy slide, mainly because there are significant factors when you're looking for hypercoagulable patients. So a hypercoagulable patient is a patient who has a risk of thrombosis based on their physiology, a pathophysiology that increases that risk. So these patients, for example, haven't had recent surgery. These patients have not, you have not identified a malignant component. They haven't had recent fracture or illness. And generally what we find is we are testing these patients for 2 things. One is that in some instances, it may help us determine length of treatment, but it can help determine and identify a particular disorder in which we may need to check other family members, or particularly help them in certain conditions. For example, if a patient has a factor V Leiden mutation that we earlier talked about, in which they may need to go on oral contraceptives, you want to check to see if they have an underlying hypercoagulable state. So you can go through the list, but essentially patients who have very strong family history, especially in family patients who say, hey, my mom or father had an unprovoked blood clot and they were pretty young, less than the age of 50 or 45. These are patients we like to check. Young patients who present to you with no history of a provoked clot, you should evaluate these patients. APS here is the antiphospholipid syndrome. These are patients, for example, that have lupus anticoagulant, cardiolipin antibodies, or beta-2 glycoprotein antibodies. Patients who have recurrent thrombosis. Hey, Dr. Fichuri, I've had 3 DVTs. And when you are obtaining the history, all 3 DVTs were unprovoked. These are patients you should check. Patients who have thrombosis in unusual areas of the vasculature, portal vein thrombosis, mesenteric, cerebral vein thrombosis. These are patients that one should evaluate, especially looking for underlying JAK2 mutations, which can be seen in myeloproliferative neoplasms. Patients who have arterial thrombosis, these patients usually may have an underlying lupus anticoagulant. Whereas the inherited thrombophilias and most other inherited or acquired thrombophilias cause vascular thrombosis. Excuse me. Lupus anticoagulants can cause arterial thrombosis. And again, although testing can lead to increased identification of hypercoagulable states, it doesn't always alter the duration of treatment for these patients. And essentially, the major benefits of testing these patients are really for patients in which management in certain things in the future can be helpful, future major surgery, future pregnancy. So let's talk about treatment. In all patients, again, treatment determination is individualized. Remember that prior to your treatment, you must look at factors such as their bleeding risk. Can they take oral treatment? Are they compliant? And also, what treatments are available to you at the time? The most common treatments, as you can see from the list below, are things like low molecular weight heparins, which are usually given subcutaneously. They are weight-based. Fondaparinux, also subcutaneously and weight-based. Unfractionated heparin is typically an IV drip, usually given in an inpatient setting for acute thromboses. We certainly have things like vitamin K antagonists, such as Coumadin and warfarin. And now we are treating most patients with oral factor Xa inhibitors or direct thrombin inhibitors. So treatment for initial anticoagulation, primarily for most patients who are stable hemodynamically, we treat them with subcutaneous heparin, fondaparinux, and then they are usually bridged to either Coumadin or dabigatran. Patients who, however, are presenting with blood clots and are hemodynamically stable, we can now use some of the direct thrombin inhibitors in treatments like rivaroxaban or apixaban, which do not need bridging, they do not need monitoring. And these patients typically can be started in the emergency room and usually discharged the same day. There are certainly exceptions on what type of treatments you can use. We'll talk about some special populations, but women who are pregnant, patients who have active cancer, poor renal function, these are patients in which we consider special populations. And so special populations of patients treatment usually cannot be given with things like low molecular weight heparin. Pregnant patients cannot take Coumadin and need to be treated with things like low molecular weight heparin. Any patient, however, that's presenting to you with hemodynamically instability, extensive clot burdens, these patients should be treated with unfractionated heparin on a drip. Remember that these patients, because of their instability, may need surgery. They may need thrombectomy. These patients, also, we do not have a lot of studies that have looked at using things like the new direct thrombin inhibitors in patients that have extensive clot burden or hemodynamic instability. Currently, we are researching this. Underlying malignancy, most patients are now using low molecular weight heparin, but the direct oral anticoagulants are appropriate in treatment. Studies have showed this. There's one particular condition called heparin-induced thrombocytopenia. In these patients, you do not want to use heparin or low molecular weight heparin. There are non-heparin anticoagulants that are preferred. Fondaparinux has been used. We are now using some of the new direct oral anticoagulants in these patients as well. But these are conditions in where they have developed a heparin allergy. And if you do give these patients heparin or re-challenge them, they can have significant thromboses, ultimately leading to limb loss and or death. So just briefly, the direct oral anticoagulants, again, a newer treatment. The main issue with these treatments is they're expensive, they're not widely available. But the important part of these treatments is that they require no monitoring, there is no diet restrictions. When compared to Coumadin and low molecular weight heparin, they have similar rates of recurrent thromboses. And newer studies are showing that the bleeding rates, especially major bleeding, intracranial bleeding, may be less in these treatments. This is my preferred treatment in the outpatient setting. Remember that warfarin and Coumadin is widely available, but it's burdensome to patients. They do need to have their blood checked with therapeutic levels of INR. And so these really eliminate that need. And then the low molecular weight heparins are really preferred in patients in whom oral anticoagulation is not feasible. They're not eating well. They have issues with malabsorption, or it's contraindicated to use oral treatments, for example, in pregnancy. So treatment really of VTE, the greatest risk, again, is embolization is really during the first few days of the treatment. So it's really important to start these treatments immediately. Do not delay treatments. Prior to beginning treatments, it's important to evaluate their pro times and INRs and PTTs. I also do a CBC, and also I do a metabolic panel. I want to look at their renal function, their hepatic function. I want to make sure that they don't have things like thrombocytopenia or anemia, in which the bleeding risk can be higher in those patients. Treatment with things such as low molecular weight heparin is usually weight-based, usually 1 milligram per kilogram twice daily, or 1.5 milligrams daily. And when you're using treatments like warfarin or dabigatran, these patients have to be bridged, usually with 5 days of some type of parenteral treatment. Whereas, as discussed earlier, the new oral anticoagulants do not require this. The PTT measures unfractionated heparin. Warfarin, as you all know, is measured by the INR. Treatment with low molecular weight heparin does not require measurement, but if you really would like to check the anti-factor 10A levels, can evaluate this. So here are kind of, again, some factors that may influence your selection of anticoagulation in patients who present with an acute venous thromboembolism. Again, patients with underlying cancer, patients who have underlying history of GI bleeding, you must be careful what you're using. Poor compliance. Say a patient just doesn't like to take their medication. I like to use Coumadin because I can measure their levels. And by measuring, I can tell them, hey, you know what, you're not therapeutic. That tells me you're probably not taking the medication. If you're anticipating a procedure, thrombolytic use, then those are the patients you want to use unfractionated heparin. If you have a concern for bleeding patients in which reversal agents are not available, then maybe you don't want to use the direct oral anticoagulants. We do have reversal agents, but these are not universally available. Cost is also important. Of these medications, the cheapest is the warfarin and Coumadin. So this is just a nomogram when you are using heparin, how to adjust it. It's important that you guys look at this. I like to print this out and have it for my students, because when you're in the hospital, you are primarily using unfractionated heparin. When a patient is coming in acutely ill with thrombosis, I recommend unfractionated heparin. And so remember, with heparin, you have to give a bolus, and then the infusion rate is based on your weight, and the adjustment is based on your PTT. The ideal PTT is anywhere from about 60 to 110, and you will either increase your infusion rate or decrease it to achieve a therapeutic range. So low molecular weight heparin, again, some patients that I don't like to use this in are patients who are obese. It is not really well studied, but it's a great medication for home treatment. We teach a lot of these patients how to self-administer. The needle is small, like insulin needles. Again, laboratory monitoring is not necessary. Disadvantages primarily is it's costly. Again, the DOACs, the new oral anticoagulants, dosing below. Medication typically is given usually at a higher dose for the first few days and then titrated downwards. Most commonly, rivaroxaban and apixaban are used. And the trade names are Xarelto for rivaroxaban and Eliquis. So when we look at trials, by the way, current trials kind of show that rates of recurrent thrombosis are similar when using things such as low molecular weight with bridging to Coumadin. Although this can be argued because most patients are not going to be achieving an INR that's in the therapeutic range for the most part. So again, a little bit about the efficacy. I think one of the important things is that there has been noted a reduction in the risk for major bleeding. That's been quite important. There hasn't, though, been seen a very significant difference in the risk for recurrent VT and mortality. Certain other cases, by the way, that you cannot use some of the newer agents or patients with lupus anticoagulants, trials have shown that they do better with warfarin or compared to the newer agents. So the most kind of significant risk to your patients when using any anticoagulation is really bleeding. And you really need to determine that, because it helps you with the type of anticoagulation you're using and the duration. So when we look at patients, we give them, again, categorize them into low risk, moderate risk, or high risk. And what increases bleeding risk is, again, older age, fall risks, patients that have liver failure, thrombocytopenia, they're taking an aspirin or Plavix, clopidogrel, because of an underlying cardiac condition. They've had recent surgeries, or they've had a history of bleeding in the past. And so you can see in the list below the risk, based on low, moderate to high, what their bleeding risk is in the first 3 months of treatment. That bleeding risk ultimately does decrease. So if a patient hasn't bled in the first 3 months, the likelihood of a bleed after that, although there, starts to certainly decrease a little bit more. So your first 3 months, if a patient bleeds, that means that their risk of a recurrent bleed on anticoagulation can be quite high. Here again is a chart that just looks at the rate of bleeding stratified by risk in patients with VTE on anticoagulation, again, in the first 3 months, and then annually if they're low, intermediate, or high. So you can see it. And bleeding can be what we stratify. Sorry, I want to just go to here. To what we stratify as major and or minor bleeding in patients who have major bleeding, which we consider things like intracranial hemorrhage, gastrointestinal bleeding. This can be quite significant, versus a patient that's presenting with a nosebleed that can be treated typically with just direct pressure. So for patients who are presenting with uncomplicated DVT, typically we offer home treatment. Again, you do not need to hospitalize these patients. And this certainly helps reduce the burden of cost, and also patients prefer this. And you can see from the chart below kind of the outcomes where if you're treating them at home versus hospital, there's not a very significant difference. And so hospital treatment really may benefit patients who have either limb-threatening DVT or those at high risk of bleeding. But otherwise, most patients with the DVT can be treated at home. We also do recommend patients who have venous thromboembolism that they use one of the new oral anticoagulants over vitamin K antagonists such as Coumadin. Again, this will be dependent based on availability and cost. But if you look at the absolute effects, the new agents have slightly decreased risk of bleeding, slightly decreased risk of DVT and PE, although the PE and DVT risk, that reduction, in terms of its clinical significance, statistically may be challenged. Duration of treatment has multiple different factors. We look at things such as provoking and or unprovoked events. What's the risk of recurrence? For example, if a patient is presented to you with an active malignancy with a new DVT, it's unlikely that you'll recommend just 3 months of treatment. We have an active cancer, and we usually consider maybe indefinite treatment, especially if the cancer we don't consider curable. So every patient, in terms of their risk factors, their risk of bleeding, but also their preferences, is important as well. Most of the guidelines on duration are really taken from the American College of Chest Physicians, the International Society of Thrombosis and Hemostasis. The current recommendation is that if you're presenting with your first episode of a blood clot, if it is provoked or unprovoked, it really should be 3 months of treatment. Some patients, however, you can extend this to large blood clots, patients that may have presented with a hemodynamically significant PE, especially if it was provoked, a persistent but reversible risk factor. They had surgery, they had a large blood clot, you've treated them for 6 months, that risk factor of surgery has been removed. They present on oral contraceptives, they have a large blood clot, you've treated them for 6 months, you've removed the oral contraceptive. This does not apply, though, with patients with cancer. This does not apply to pregnant patients or patients in whom indefinite anticoagulation should be considered. So when we are again looking at treatment of lower extremity proximal DVTs, this is just a quick chart that you can look at. Is there evidence or risk for early limb ischemia from a massive DVT? If the answer is yes. If there is a contraindication to thrombolysis, for example, there's no bleeding risk, some of these patients should go for thrombectomy. Now, some of you may question thrombectomy. What is the role of thrombectomy in treatment of pulmonary embolism or DVT? Thrombectomy primarily we reserve for patients who are presenting with very significant DVTs of the lower extremity, especially if they're presenting with things such as limb ischemia, large pulmonary embolisms that are presenting with hemodynamic instability. However, do we use this routinely? And the answer really for DVT has been no. It has not really been shown to kind of change outcomes. Some people have argued that it may help with what's called post-thrombotic syndromes, which can include chronic pain, chronic swelling. But these certain studies are not showing a very significant effect of thrombolysis unless we're talking about those high-risk patients. In addition to that, filter placements, you may have heard about IVC filter placement. We really use these in patients who are at risk of bleeding or are presenting with a bleed. We do not use these routinely. IVC filters can increase the risk of blood clots. Distal to it, IVC filters in general, if you do place them, you want to make sure that you can retrieve them. So it has not been something that we routinely recommend in practice. If there's a patient who has a contraindication, again, to anticoagulation, a high-risk bleeding patient, then put in a retrievable filter. So this here kind of tells you a little bit about why some patients are not recommended to undergo long-term treatment more than 3 or 6 months. If you look, if a patient has a first VTE that's provoked by surgery, their risk in the first year after anticoagulation is only 1%. So that's why would you want to put this patient on for longer? You're increasing their risk of bleeding. Cost is also a factor. But if they have an episode of an unprovoked VTE, then that risk, as you can see, is higher in that first year. If they have another unprovoked, it goes even higher. Who needs indefinite anticoagulation? This is a difficult question, but I think the important parts are certain patients that have risk factors that are not reversible. Again, an underlying cancer patient. Certain patients who have multiple blood clots that are unprovoked. Patients who present to you with blood clots in unusual parts of their body, and you are identifying an underlying cause, such as a lupus anticoagulant that is persistent. And so indefinite anticoagulation is really reserved for a set number of patients, and where you're determining that this patient has a risk that is not reversible, a risk that is persistent, and or has an underlying disease that can increase that. One of the things sometimes I see in practice is an unprovoked patient who is morbidly obese, and I recommend typically indefinite anticoagulation unless they lose weight, because if not, they will have persistent risk that is there. So indefinite anticoagulation is really based on multiple other factors of the underlying patient and other comorbidities. So again, here are just a list. In terms of some of the hypercoagulable conditions, some patients ask, well, if they have a factor V Leiden mutation, do they need to be on long-term treatment? And the answer is no. Just because you have an inherited thrombophilia, if it's your first event, the recommendation is not for long-term indefinite treatment. So one of the questions we sometimes get is a patient comes in, hey, Dr. Faturi, I'm taking aspirin. I have a history of cardiovascular disease. Should I continue my aspirin if I'm on the blood thinner? The answer is no, stop it. Look at the risk below if you continue your aspirin and anticoagulation. It's quite significant. The only time we don't suspend it, obviously, if the patient has a stent that was recently placed, but suspending aspirin is what we do consider the current recommendation, or clopidogrel. So this is just very briefly on what we call post-thrombotic syndrome. Again, some patients who develop lower extremity blood clots, DVTs, is certainly where it's close to the valve may develop these particular syndromes. About 30 to 50% can. And these patients can develop, again, chronic pain, skin changes, swelling. Some of the adjunctive therapies can include compression stockings. Again, we talked earlier about thrombolysis. There may be some decrease post-thrombotic syndrome, but statistically it hasn't been shown to be very significant. And remember that thrombolysis does confer a pretty significant bleeding risk too. So there's some low certainty in evidence and therapy that may be considered for patients. Again, low risk of bleeding with thrombolysis, or a value rapid resolution of symptoms and prevention of PTS. So when you are again seeing patients who may present to you now with a bleed, they're taking warfarin, they're taking low molecular weight heparin, and they're coming in with a bleed. First of all, if you get a telephone call that your patient is bleeding, have them go to the emergency room. Do not try and assess this patient over the phone. You want to first assess the bleeding. How severe is it and where is it located? A nosebleed versus gastrointestinal bleeding. What agent is the patient receiving? If they're receiving one of the newer agents, then these tend to have a longer half-life, and these patients may need urgent treatment. When did they last take their treatment? I took it 4 days ago versus a day ago. This helps you determine the half-life of these treatments. And did the patient intentionally take too much treatment? An elderly patient, instead of taking 1 dose of warfarin, took 2 doses of it. Do they have underlying renal or hepatic disease in which clearance of the anticoagulant may be decreased? Are they taking other medications? They're taking Coumadin and on top of that aspirin or clopidogrel where the bleeding rate increases. Again, major and minor bleeding, as you can see, major bleeding typically are kind of bleeding in enclosed spaces like intracranial, gastrointestinal bleeding. This is also defined on how many units of blood a patient is requiring, how the degree of drop in their hemoglobin. And these patients who have major bleeding, they really require urgent management. We place them in an ICU. They are monitored carefully. They are given packed blood red cells, certain interventions for management like endoscopy, interventional treatments are required. And we typically then apply certain treatments to either help with drug removal or help to reverse the effect of the drug. Prothrombin complex concentrates, activated prothrombin complex, given these patients things like dialysis in extreme cases, especially on some of the new agents like dabigatran. And so when you're seeing a serious or major bleed, we recommend intensive care setting, hemodynamic support, blood transfusions, and then working on reversing these agents. Now, some of the newer agents, one of their major issues is that if you have a big bleed, it is hard to reverse these. We do have agents. For example, the direct factor 10A inhibitors, we are now using Andonexit. This is very expensive. Even working in Manhattan, there are certain hospitals where obtaining this is not as common. The treatment for things such as reversal of patients who are presenting with warfarin toxicities who have significant bleeding, patients who have low molecular weight, heparin with significant bleeding. These are the patients where you can use prothrombin complexes. And you can also certainly try these in patients who are on some of the newer agents. But I think this is an important aspect of if a patient is presenting with the bleed on some of these newer agents, you have to be cautious in terms of trying to reverse these. Are these medications available to you? So this chart just kind of looks briefly at, again, some of the reversal agents. I won't go through it, but it is important that you guys have this present with you, especially if you have access to some of the new oral agents. So let's just talk briefly as we're wrapping up, just some cases. This case is a 48-year-old male patient who has an unprovoked DVT. He comes in and has left leg pain and swelling. He has normal hemodynamics. How would you guys treat this patient? Would you consider just anticoagulation? Would you consider thrombolysis and anticoagulation? What is your approach for a patient like this? So when we look at a patient like this, will we say, well, he doesn't have a lot of medical history, so we know he doesn't have a lot of risk factors. He's not on any medications, which may increase his bleeding risk, or medications that may have increased his blood clot risk. He only has leg pain. His hemodynamics are stable. I think when we look at his vitals, his heart rate looks good, blood pressure looks good, he's saturating well, less likely to have something like a large pulmonary embolism. I think this patient can typically be treated with just anticoagulation only. Thrombolysis, I just wouldn't recommend in a case like this. Compression stockings are not really used in the acute setting. And then a filter, this patient is not bleeding, and filter insertion. And briefly, I'm just going to talk to you guys about a few cases that I have in my practice, just so you can get an idea of what you may encounter in real life. So I have a 31-year-old female patient. She came to see me. She presented with a question. She wanted to start oral contraceptives, and she stated that multiple members of her family had a blood clot. When we got further history, how old was your mom? Her mom was 35. When she had it, she had an aunt that was in her 20s that had it on the maternal side. And the question is, would this patient be appropriate for evaluation of a hypercoagulable workup? And the answer is yes. We identified that the patient has a factor V Leiden mutation. This patient was recommended not to go on oral contraceptives. As you recall from the chart earlier in this slide, if you have a factor V Leiden mutation and you're on an oral contraceptive, that the risk of a VTE can be high. Now, remember that oral contraceptives, there are multiple different types. The oral contraceptives that primarily are estrogen-based are really the culprits in causing blood clots. Most of the newer oral contraceptives are progesterone-based for this reason, because of the risk of VTE that was high. The second one, 54-year-old male patient, he had a syncopal episode with hemodynamic instability. It's found to have an unprovoked pulmonary embolism. So this patient, comes into your ER, you'd probably start him on unfractionated heparin. If he is not improving with pressor support, then you may want to even consider urgent thrombectomy. Now that he's stabilized, though, you find that he's an active smoker. Was there any other further testing you'd consider? What I'm trying to get at with this particular question and what we worked up in this patient was, well, we do know that in a subset of patients with an unprovoked PE, that about 10% of these patients may have an underlying occult malignancy. We know he's a smoker, and so I pan-CT this patient, scan of the chest, abdomen, and pelvis, and we did find what appeared to be a mass in the left upper lobe of his lung, which turned out to be a stage 1 adenocarcinoma of the lung. Number 3, 50-year-old presents with slurred speech, headache, facial paralysis, and he's found to have a hemorrhagic stroke. Incidentally, he has a right lower extremity swelling with findings of a DVT. How would you manage this patient? Well, this is the patient where we would say this patient needs a filter placed. He cannot undergo anticoagulation. He's presented to you with a bleed, a hemorrhagic stroke. You place in this patient a underlying retrievable, remember retrievable, that's important, filter. And once he's stabilized, once he's cleared by neurology, you can then anticoagulate this patient. But there's a period of time that you'd have to wait. Number 4, 74-year-old presents with painless jaundice. She had come to see me for weight loss, abdominal pain. An underlying CAT scan we completed, which showed a pancreatic head mass. Incidentally, he was also found to have a pulmonary embolism. Question is, what type of anticoagulation would I consider and how long? So he has painless jaundice with a pancreatic mass, likely indicating pancreatic cancer, which is a significant risk for thromboembolic disease. This patient was placed on low molecular weight heparin, and then he was ultimately switched to the new oral agents. As we know from the studies, the new oral agents are effective. Duration of treatment, well, pancreatic cancer, until his treatment is completed, we started the patient on neoadjuvant chemotherapy, subsequently took him to surgery, and the patient will remain on treatment until we have evidence that his disease is cleared. And the last case was a 32-year-old female who presented with an acute pulmonary embolism, unprovoked. She's young. We evaluated for a hypercoagulable condition. She was found to have a lupus anticoagulant. Lupus anticoagulants or antiphospholipid antibodies, they have a significant risk of blood clots. And this patient, the question is, what anticoagulation would I recommend? I recommended warfarin, Coumadin for her. Why not the new agents? Because the new agents failed in a recent study to show superiority. In fact, they were not as superior to warfarin. So this patient was placed on lupus warfarin, goal INR 2 to 3. You must repeat the lupus anticoagulation testing in 10 to 12 weeks to see if it's persistent and or not. Some of the future kind of things to look at in terms of research in this field are what patients with DVT or PE would benefit from thrombolytic therapy. What is the optimal strategy? Right now, we know, and as I mentioned earlier, who it would be of benefit in hemodynamic instability, patients presenting with limited ischemia. But what about that young patient with a large blood clot who you want to prevent post-thrombotic? Is there a better study that we can look at for this? What patient populations would benefit most for incorporation of greater than 1 prognostic scores, D-dimers, and or ultrasound when you're trying to determine after completion of primary treatment if they need further treatment or not. As we recall, in the first 10 years, the risk of a recurrent DVT or PE can be elevated. But sometimes we don't know which patients that need longer term treatment. Even if it's provoked, we sometimes know that once you've had a blood clot, even if it's provoked, there is a slight risk that it can come back. Doesn't mean they need long-term treatment, but that's what we need in our future research to identify. What about the impact of different risk factors on the rate of recurrent VTE? Can we use a lower dose of some of the newer agents for secondary prevention? I do this in my practice, elderly patients whom I think will benefit from longer term treatment. I have to dose of the oral agents and place them on them long term. And then what about a patient who is on an agent and has a breakthrough blood clot? How do we manage these patients safely? Why did the patient have a breakthrough a blood clot, especially if the patient was compliant, if their treatments were found to be therapeutic? And then other questions are, what patients could continue antiplatelet therapy when we began anticoagulation therapy? And if a patient does require antiplatelet therapy, what is the kind of safest anticoagulant to use? Thank you. I hope that was helpful to everybody. I'm sorry it took a little bit of time. It's a big subject, but if anyone has any questions, I'd be happy to help out.
Thank you so much, Dr. Suleiman. It is an honor to have a lecture from you. Really enjoyed the lecture. And we will have question from the students. Dear student, please raise your hand if you have any question. Although I don't think any question is remaining. You have explained everything brilliantly.
No problem. Thank you very much to you all. If anyone has any questions after, I'm happy to help out. The doctor can provide my contact information. I wish you all success, and I hope to see you guys for a future lecture. I will be signing up to help out with another lecture with you guys.